seconds. Hello, everybody. Welcome to the Hot Topics session here at the first day of the ERC 2021 Guidelines Conference. I'm Jaz Saw. I'm an intensivist in Bristol and chair of the programme committee, and just introduce my co-moderators. So Anna.
Hello, everyone. I'm Anna. I am an anaesthetist in Berlin. I'm currently working at ITU, and I have been involved in cardiac research, cardiac arrest research since 2015. And yeah, well, over to Jess.
Yeah. Hi, everybody. I'm Jessica Rogers. I'm an emergency medicine registrar in London, and I'm the current chair of the Young ERC.
Excellent. And do you want to introduce some of the panel members?
Yep, so we've got a great panel joining us today. So firstly, we've got Ben Abella, who's joining us from all the way over in the States. He's a professor of emergency medicine in Philadelphia and a big name in our sister organisation, the AHA. So I'm sure some of you will recognise him. And then we have Koen Munshurs, who I'm sure needs no introduction, but is our current chair of the ERC and a professor of emergency medicine in Antwerp.
Hi.
Anna.
Yeah, and I will introduce Jerry Nolan, who is also very well known. He's an anaesthetist and ITU consultant, also the editor-in-chief of the Resuscitation journal and immediate past chair of the ERC. And also I will introduce Hildegunna Svavadotter. She's the secretary of the ERC and chief executive of the nursing at a hospital I can't pronounce the name of, Akureyri.
In Iceland. Excellent. Well, it's great to have you here. For those of you in the audience, please ask questions on the Slido app in the Congress platform, or if you're watching on YouTube, the Slido numbers along the top of the YouTube feed. I'm going to kick off, and I'm going to start with Koen, who's the current chair of ERC. And clearly, we've had a day of our new guidelines. So tell me, what sort of interested you today? Have you picked up on any things you thought, oh, that was interesting?
Yeah, two things, Jess. Firstly, system saving lives. And I'll tell you why. Because usually in these conferences, and certainly the guidelines conferences, there's some changes in, say, energy levels or adrenaline dose, things you can easily learn or teach and then implement. But changing the system, that's something else. And this is the next step many systems need to take. It is change. And that is not just something you teach in a lecture and then you practice. So it's a whole different game. And I think this is probably one of the most innovative things in this conference and for the near future. And the second thing is the patient is central, and that goes to ethics. I think we're slowly realizing the importance of the patient, so that the most important during the resuscitation is the patient. And so it's not just doing CPR on anyone, anytime, as long as you wish. We need to consider the patient as well. And I think that is the second and also very difficult thing to achieve. Is not just a drill or a skill or a technique. It's the patient, him or herself.
Very good points
from today.
And the system saving lives is actually a new section of the guidelines. So hopefully it'll sort of, lots of people will pick up on it. I'm just going to, Jerry, what about you? You've been involved in quite a few of the sessions. So you've been involved, you've seen all the questions from the audience.
Yeah, I mean, well, I'll pick one that I wasn't involved with, which I thought was very interesting, is around the dispatch. Quite a lot of information around dispatch. Very interesting stuff around the use of video, live video at the time of a cardiac arrest and how that can be fed into dispatch and so forth, with a lot of challenges, including ethical challenges, of course, which I thought was very interesting. But in terms of sessions I've been involved with, I think probably for the post-resuscitation care session, which I chaired just in the last one, surprising amount of interest coming in on Slido on the questions on things like hemodynamic targets, ventilation targets, things that don't necessarily get to be top of the list of people's interest, but very high interest there. And inevitably, there were questions around TTM, which of course, unfortunately, we were unable to address in terms of TTM2, but hopefully that will come out soon.
Yeah, and Hildegard, anything that took your eye today in the guidelines? Still another day of guidelines to come tomorrow. So, anything you picked up on today?
No, mainly what I noticed also. I agree with Koen that the system saving lives is a very interesting theme of our work, because we know that system is very important, and system is also built on different groups, and that links to my topic of tonight, the diverse group of people, because we cannot do it if we are only, one group of people. And also what I thought was fantastic today, to see all those young people participating. I thought that was a very good sign.
Excellent. Yeah. So Jess, do you want to just point out? So for the first time, actually, we did it in Manchester as well. We've sort of tried to have co-chairs from the Young ERC group. Do you want to just say a bit about that?
Yeah, absolutely. So the Young ERC was set up about 5 years ago and has slowly been growing. We're now a group of about 12 on the committee, I believe, from various different backgrounds, different countries around Europe, all with slightly different interests. And then last year for ERC 2020, and then this year we've been given the opportunity to sit in on and co-moderate some of the sessions, which has been really good opportunity for us to get to know some of the other names within resuscitation. We've also got our own Young ERC session tomorrow, which is a competition. So if anyone fancies popping into that, we thought, as this was a guideline session, that we'd look ahead a bit more into the future and ask people what they thought would happen in resuscitation in 2040. And we had some really interesting topics come up. So we've got 6 really interesting, very different ideas that are going to be presented in a Dragon's Den style session tomorrow. So come and check that out if you're free, and vote for your favourite.
Right, that does sound good. I was going to say, one of the things, Jerry, you mentioned dispatch and video. Do you think now we're doing these sort of Zoom calls, people will be far more up, and you can do WhatsApp calls, and there'll be far more? It's getting to the point, like, why don't the ambulance service do it already? Yeah, because you're doing it with your mates, you're doing it at conferences, you do it at work. So it's almost become just talking to someone on a phone is no longer the normal, is it? What do you think of that, Jerry?
Yeah, I'm sure you're right, Jazz. I think sort of generally there'll be knock-on consequences of that, and all of us, everybody out there, us as in healthcare professionals, have been using it a lot, and so for, the lay people out there. So I think they'll be much more happy about using some of those technologies for sure. Sadly, of course, and we'll perhaps get on and talk about COVID, and we've experienced the fact that families have been unable to see their loved ones in hospital, and then having to use video technology to communicate in that way. And so, as a consequence of that is they become, sadly, incredibly used to it.
Yeah, Ben, I know you didn't see the guidelines, but some of the big things that I think they're very in line with the American guidelines, and the differences are actually relatively subtle. But the things that I know you've produced some guidance in the States on systems and survivorship. Any comments on those issues?
No, thanks, Jess. I agree. I think there's good alignment this past year between the American Heart Association guidelines and ERC. I do think survivorship is becoming a big topic. And in many ways, I say that's a marker of our success as a field, that we're making progress. 20 years ago, survivorship would have fallen on deaf ears as a concept, because we didn't frankly have enough survivors. So survivorship is really a growing pain and a good one for our field. The American Heart Association did put out a scientific statement on survivorship, and there's been a lot of interest there. So I think that's concordant. I think also in other areas as well, there's good overlap. In the United States, the systems issue remains a challenging one. I think in Europe, there's, for a lot of structural reasons, it's easier to think about systems of care in many European nations where the health systems are better integrated and better aligned. So that remains a major challenge for us. Nonetheless, we recognize across the Atlantic that it's an important thing, and certainly our guidelines do speak to thinking about systems. Of course, we have the challenges in the United States of having a very fragmented health system, so it's sort of going to be harder to actualize that.
Right. I was looking at the questions. I can't really see any questions so far on any hot topics from during the day, apart from where is the fire? Because it's meant to be a fireside chat. Unfortunately, Zoom didn't quite produce us a fire background we could all share. But I'm gonna move on. I'm gonna hand over to Anna because she's got a topic she wants to discuss. And do start firing in questions. So, any questions, the panel are up to any questions on any topic. So do ask on the Slido.
Hello, everyone. So I wanted to open the discussion about COVID-19 and the impact on resus and cardiac arrest care or critical care in general. And Enrico Baldi has presented today his results and findings saying that it has a negative impact on cardiac arrest outcomes of patients. So I would like to see if there's anything in the chat which has currently not happened. And I will direct this question also to Jerry to answer and while I scan the chat. Thank you.
Thanks, Anna. Yeah, it's a big topic, of course. I mean, COVID has affected us, everybody in the whole world, pretty severely. Hence this Zoom meeting, of course. In terms of cardiac arrest, it's affected both out of hospital and in hospital cardiac arrest. I think we tend to think a lot more about out of hospital, but there's a lot of data coming through in hospital as well. General terms, yes, an increase in the rates of out of hospital cardiac arrest, and sadly a reduction in survival, with an increase generally in the non-shockable rhythms. What I think is very interesting is the fact that it's not just the direct consequence of COVID. It's not just people who have got COVID and are then, because of the disease, having a cardiac arrest, which of course in general would be associated with a bad outcome. It's the indirect effects. It's the fact that people who've got coronary artery disease, ischemic heart disease, are not presenting early enough. They're very afraid of coming into hospital. And of course, those people are then going on to have cardiac arrest, whereas outside of the pandemic, they would have come into hospital and hopefully been sorted out before. There are also all sorts of knock-on effects in terms of the demands placed on the emergency services. Therefore, there could be delays in getting to these arrests as well, because they're being diverted to attending to COVID patients. So there's massive consequences. In hospital, we also recognise, I think, certainly in association with COVID positive patients, a reduction in survival rate from cardiac arrest. Although I have to say, the data I've seen is mixed. Some of the data, and we've got that big study from Wuhan, it came out very early on, showing almost no survivors from in-hospital cardiac arrest associated with COVID. But in contrast, there's a study very recently from Denmark, I think it is, or it's either Denmark or Sweden, certainly from Scandinavia, that's just been published in the European Heart Journal, which shows slightly better outcomes, actually, even amongst patients with who are COVID positive. So it's a mixed picture, but it has massive implications on outcomes. It of course has massive implications on guidance in terms of what we do, and we'll perhaps come on to that in a moment. And it has massive impact on education. And we all know that there's been almost a shutdown of courses across the world that are just beginning to restart now. So many facets to this disease and its impact on cardiac arrest.
Yes, thank you, Jerry. I've, as a clinician as well, noticed that people have the fear of entering the hospital and definitely delay care to a certain extent. So it's the other spectrum of trying to seek for help for maybe the most important things, and for smaller injuries, they used to attend very easily. There's another question from the live questions coming in. It says that the COVID regulations might confuse the lay people during the pandemic, especially considering mouth to mouth or covering mouth and nose during out of hospital cardiac arrest. What is your view on this?
Yeah, I did spot that question earlier on. That's a tough one. So we've in these guidelines really not focused on COVID. We had separate COVID guidelines earlier on. And of course, whilst the pandemic is still ongoing, really the COVID guidelines, trump the standard guidelines, if you like. So in other words, people, whether they be lay people or healthcare professionals, should be following the guidance that we offer in COVID and taking the necessary precautions. The real challenge we've got is deciding internationally, really, at what stage we transition to a state where perhaps we consider that risk to be less and therefore start to go back towards doing the standard approach to resuscitation. And I'm talking about both basic life support and advanced life support. And I don't think there's an easy answer to that. And it might be that it's different in different countries or even in different regions of countries. And I think we just have to deal with that as we come to it. I'm not going to sit here and predict when we're going to go back to standard CPR guidance. I'm not going to be that brave, I'm afraid.
Maybe some of the other panel have views on that. Ben, or?
Yeah, so actually I wanted to go to the general topic of sort of CPR and COVID. In how it's handled in the United States, we have a major problem that relates to some of this discussion, that many patients are not getting CPR as they would have beforehand, bystander CPR. The other problem we're seeing in the United States, which I find very worrisome, is the amount of EMS transports of cardiac arrest has really fallen. Many EMS agencies in the United States are underfunded, and they have not enough funding for PPE and other precautionary things. And so they've taken the tactic that if someone has suspected COVID and they can't get them back in the field, they will not transport them in active cardiac arrest. And so we're seeing far fewer patients being delivered to hospital due to presumption of COVID infection. And so I really worry, the way I frame this, I worry about the 45-year-old myocardial infarction patient who goes on to VFib arrest, where he has the bad misfortune of having been short of breath for several hours before he collapsed, and his spouse happens to tell the US EMS agency that, and they say, oh, he was short of breath, this might have been COVID, and they don't transport him, and it's a failed opportunity to make a save. So we're seeing that, and there's been actually some lay press in the United States from Los Angeles, some other places where this is becoming a major problem. There's a lot of confusion out there. Actually, I also want to respond to another point that Jerry made about survival from in-hospital COVID cardiac arrest. Jerry's point is very important, that newer reports are suggesting that cardiac arrest from COVID or related to COVID may be survivable. We had a report from a multi-center group in the United States, led by an Englishman on my team, actually, showing that in the United States, in-hospital cardiac arrest related to COVID is survivable, with a 30-day survival that approaches non-COVID cardiac arrest. And so I think Jerry's point about the earlier cases, Wuhan and other reports, is important. Early on, there may have been a self-defeating prophecy. Hospitals were overrun. People thought this was a dreadful disease. Over time, we're getting better at the disease. We're getting better at managing it, and we're recognizing that a resuscitation can be done safely in the hospital. So I think it's really important that all of us as champions for this field help spread the message that COVID arrest is not synonymous with 100% mortality.
So any questions about COVID for the panel? Anna, are you looking at the feed?
Yes, I've just checked, but there's been questions to other topics we're going to hit on, so I might return to this later. That's all right.
Okay.
But I've picked up just one.
There's
that's
one
related.
Yeah, Sweden arrest. Sorry.
Oh no, I've picked up a different one that was just asking, with the delay due to COVID, so with the 6-month delay in releasing the guidelines, were you able to introduce any other research or include any other data that you wouldn't have had otherwise if they'd been released originally last year?
Do you want me to comment on that, Jerry? In that, I think the uncertainty with COVID has always been the risk of transmission to rescuers. And clearly it depends on the risk of the person who you're doing CPR having COVID, and then whether the interactions during a resuscitation attempt are going to increase your risk of of risk of transmission, and that then becomes, you know, the number of people involved, whether chest compressions generate aerosols, whether airway interventions generate aerosols, whether defibrillation generates aerosol. And the truth is, we still don't really know any more than we knew at the beginning of the and so we've always practiced the precautionary principle that we're recommending, yeah, PPE against aerosol generating procedures for resuscitation. And I think where things may have improved is people are wearing masks in the community now. And so both the victim and the rescue is likely to be wearing a mask. So hopefully you can cover the victim's face and your own face. So there are mitigations in place. And if you're in a setting with a low instance of COVID or where people have been vaccinated, the risk of transmission is going to be much lower than in other settings. So it's actually quite hard to write guidelines on this. And we're sort of making it up a bit as we go along, but practicing the, you know, rescuer safety, the first bit of CPR is, rescuers safe. And so it's always going to be an issue, I think. Kuhn or Hildegard, any comments on that?
I was just going to add one thing, Jazz, to what you were saying. So critical in all of this sort of CPR and COVID is the billion-dollar question: are chest compressions both aerosol generating and aerosol dispersing? And the answer is we don't know that at the moment. We've gone, as everybody knows, on the safe side. We've made the assumption that there is a risk of generating and dispersing aerosol with chest compressions alone, but we don't know if it's true. And there is a number of investigators now are looking into this, and I hope that very soon we'll have a fairly definitive answer to this. And that may change, of course, some of the guidance that we've got.
Yeah, I just wanted to add that when we wrote the COVID guidelines, the ERC COVID guidelines, say, when was it, in March, April, May, there was so much we didn't know. I'm sure there's still a lot we don't know, but I do think that in the clinical environment, we are more organized. We have a better understanding of the risks. We are better protected. You know, usually there is enough PPE now. We have seen more patients. We are, emergency departments and EMS are better organized, and we do have, I think, a better clinical understanding and approach, a daily approach to this type of patients. So that is, in a way, for me as a clinician, more reassuring. I'm sure there's more we don't know compared to what we do know, but at least some uncertainty is controlled now. That is at least my impression.
Okay, I was just thinking, is there anything on the feed on any more COVID questions, or shall we move on?
I have picked up one more. It came from Kelly, and she's just said, can we clarify, please? We are following the COVID 2019 guidelines, and when we are COVID free, are we following the 2021 guidelines? Jerry, are you happy?
Yeah, so the question is, I'm sure we will be following the 2021 guidelines when we're COVID free. I mean, that's easy to answer. The question is when are we COVID free? And that is almost impossible to answer. And we're going to have a transition between the two, I think. I think Leo's made a comment on the slide at one point saying, will we ever go back to the sort of pre-pandemic period, or are we always going to have slightly more precautions because of the risk of infection transmission? I don't know for sure the answer to that. There is a possibility that this is going to go on for a very long time, and that we've got the potential threat from COVID-19 or son of COVID-19 when it comes along, for many years to come. And I think it's very difficult for us to predict at this stage how it's going to pan out.
I was just going to point out, I think the 2021 guidelines still stand, and the COVID guidelines are in effect modifications on how you do parts of the guidelines. So how you manage the airway, how you protect the rescuer. So I think ultimately for basic life support, the issues about the guidelines, 2021 guidelines, actually the differences between the 2015 and 2021 are actually relatively subtle in most areas. So it's actually, the guidelines haven't changed that much to mean that you can't use the 2021 guidelines with the COVID modifications. I was gonna hand over to Jess now, because I think we need to move on topics. We're getting to 25 past the hour. So Jess.
Yeah, so we'll take the conversation in a slightly different direction. And I'm going to go to Hildegard for this. So something that's quite topical in medicine and in all things really at the moment, certainly in the media, is diversity and how companies are dealing with diversity and increasing that within them. And that's something that's been going on in the background or has started to in the ERC now. Would you like to tell us a little bit more about what the ERC has been doing for that?
Yeah, thank you very much for that, Jess. Yes, I think it's perhaps a good time now in the evening to step back a little bit and give the science a little holiday, if we can say that, and think about something else. Because diversity is something that affects all of us. And we know that it has to do with different characteristics in group of people, like gender and age and culture, nationalities, professionals, etc. And sometimes we just have to step back and think and examine, what is the diversity around us. So in that sense, we decided to look at ourselves and try to get some kind of answers to the question if ERC is diverse enough. So, and if we had to look better in this matter, at least what we noticed without even, doing any kind of study is that mainly the executive committees of the ERC, and when I talk about executive committees, for those who do not understand that, we are talking about the board, the General Assembly, and the different committees who are leading the activities within the ERC. And just by looking at the names and looking at the compositions, we could see that there is a lack of diversity in the ERC. And of course, we know that ERC is the umbrella organization of different group of people, professionals, nationalities. And we would expect the ERC to be represented as such in all our activities. So we can see that in the executive committees and all the resuscitation activities. So what we decided to do together with the leadership of the ERC is to, dig a little bit deeper into that. And I was asked to take a lead in that kind of informal task force, if you can say that. And I got a group of people together, mainly women, because we can say that, within 2 months, I'm going to step out of the board, and that means there will only be men in the board. So I think we at least decided to look at how are we doing with women. But of course, diversity has to do with something, much more than only gender. So just so, having said that. So what we did is that there was an informal group of women who decided just to look at some kind of statistics about the composition of the committees. And the results were quite interesting, I have to say. But of course, fantastic people doing all the work in the leadership, but I think we can be a little bit more diverse in all our work. So we did some statistics, and we decided also to have some interviews with a few people, which we actually handpicked. So this is not the idea of, I would say, a very strict science work, but sometimes we also need to step back out of that. So we had some interviews with some people, and we asked them about, their different perceptions of how ERC appear to them in terms of diversity, from the point of women, from professionals, from a national point of view, from young people. And we have got some very interesting results. We are still working on it, but we have some ideas, and I can tell you more about that if we have time on that later on. But we are mainly talking about here to look at the leadership positions, because we can see that in congresses and like now for those 2 days, I can see very good signs of diversity, which I really like. And I was really pleased to see that today, to see all those young people moderating, women even, presenting and different professionals. And I think this is what we should do, because we all know that resuscitation is done by diverse group of people. And we need that also to be reflected in all our, leadership positions. So that's mainly what we want to do. And I think this is, I would say this is only the first step of our journey, because this is something that we have to look into on a long-term vision. We have to put forward some kind of strategy on how we want to be diverse, because this is a hot topic now. If you look at different organizations, diversity is a word that you can always see in the strategy of different organizations or societies. So it's important for us to do that as well, because we should be a role model there. And the role model is also a key word, because in order to be diverse, people have to have role models who they want to look up to and perhaps do, and what can I say? All know what I mean by role modeling. And we have to do that. And we know that, for example, if there's no woman in the board, I think it's quite difficult for the next woman to step in unless we do something about that. So we have to really be keen on thinking about how we want to make ourselves diverse. But we can do it. I'm absolutely sure we can do that.
Yeah, you say it's very topical at the moment. Maybe we open it up to Kuhn as well as our current chair. Where do you see the future of the ERC? What are the big things that you'd like to tackle from that point of view?
I think I'm fully supportive, of course, of this initiative that's being taken by Hilde Gunnar and others. I'm convinced that diverse groups work better, so we can only improve step by step. It's a culture. So it's quite difficult to achieve diversity, say, overnight, and it's a work of years, but it needs to start somewhere. So I'm absolutely sure that this will bring the ERC even further. We are a network of many countries and many nationalities, but that needs to be reflected in the leadership as well. But I was actually keen on hearing Ben's vision about diversity, because I'm sure and I know that this is for American Heart also a very important issue and at the front of the agenda.
Yes, no, that's right. Diversity is a huge issue in the United States right now, and I'm sure many of you have followed some of the recent struggles in my country around race and gender. So there's really been provoked a major national conversation, I would argue a long overdue conversation about gender equality, racial equality, that spans far beyond medicine. But to bring it to medicine, there's been enormous efforts of late to improve diversity in medical institutions, the American Heart Association, and speaker groups. And I applaud the American Heart. Actually, they've done a very nice job of this. They've really put that as a central pillar of what they do. I think it's important. It's especially important in the United States as we're very much a country of immigrants. And we have a lot of minority groups where it's important to have their voices heard, to have physicians who understand their cultural context of disease, and so forth. So and the American Heart Association is definitely making it a key pillar of activity moving forward. So we're very much in agreement with this.
Can I add something to this, Jess?
Yes.
I'm glad to hear that from you, because we also, what we need to do when we talk about diversities and trying to make the groups bigger is that we also have to look at the different expectations of different groups. And we all know that young people, they have different expectations than people who are older, are above middle age, for example. And family life and different responsibilities is something that has to be looked at. And the same appears also with women as with young people in terms of family life and responsibilities. I'm not saying it's not for the male, of course, but as I say, different groups have different expectations. But at least what we know that with different groups, we have different perspectives. And for me, I always look at group work like a good and a nice piece of a puzzle, where you have to have the different pieces all put together in order to have the best picture out of that.
Yeah, absolutely. There's a lot of comments coming in agreeing with that, and people picking up as well on it not just being physicians, and increasing that diversity in terms of the other roles as well. So our nurses and our paramedics and things like that, which I know is something we'll also be looking at to try and improve.
Yeah, that's hopefully something that we will, like Koen said, do on a long-term basis. But at least I think what we have done now is to take the first step, which is to raise the awareness and talk about that, because otherwise nothing is going to happen. So at least I think this is the biggest step, and we have definitely done that.
Yeah. Can I just add, Jess, that there's great opportunities later this year, because our science and education committees need renewal of their members. So this is an exceptional opportunity and a chance this year still for new people and also for selecting diverse groups, which is not the case currently. But there are a lot of opportunities, later this year.
I had a question, because ultimately for the ERC and many organisations, they get people nominated from other organisations, and ultimately it relies on old men like me and others, stepping down and letting new people come in, and that is one of the challenges, where you do have people who've been in roles for a long time, and ultimately, people need to be moved on for new people to come in, and it's always a challenge for organisations to do that, And I know I was going to say to Ben, because the AHA turn over their chairs a lot quicker, don't they, and stuff, to keep that momentum going. Is that right?
Well, that's right. So the AHA has really put a strong structural sort of set of rules around succession. So in many AHA positions, you sort of have 4 or 6 years and that's it. Now, there's pluses and minuses to this, of course, because you lose a little bit of the institutional memory, some of the continuity. So there needs to be a balance. But just as an example, the Resuscitation Science Symposium, as a relative newcomer in American Heart Association, actually never imposed those rules. So the chairs of the Resuscitation Science meeting can stay on sort of at will. And one of the big changes that I implemented during my time is we finally put a stop to that. So this actually will be the last year that I will be leading RES, hopefully live in Boston in November 2021. I'm voluntarily sort of throwing myself out the door. And I think it's for that reason. I think, it's time. I've been doing it for 8 or 9 years. It's important to have new blood. And I'm pleased to bring on Sarah Perman as our new co-chair, a fantastic female voice in resuscitation science. So, that's very much in the culture of AHA. I think it's incumbent on volunteer leaders to sort of know when their time has come. And that doesn't mean they can't be involved. That doesn't mean they can't have a voice, but it's important to make space at the table for newer and younger leadership.
Yeah, absolutely. I think as you've just alluded to there, Ben, it's that combination between allowing those people who've been so involved with these organizations for so long and have put their life's work into it to still be part of it, because they have so much experience and so many skills and things to give, but to bring some new voices in as well, so that things don't just stay kind of risks being static. So it's an interesting balance to try and hit.
I think that's also very important. And of course, think about the mentorship, for example, from the like I was saying, the old wise people to teach the younger generation, because this is what keeps the turnover going. And we have to make sure that we definitely keep that rolling.
Okay. Any final comments, Jerry, or anybody else on the topic before we move on to anything else?
Well, the only thing I'd add, Jazz, it's very much something we're looking at. Obviously, with my role as editor-in-chief of the journal, diversity is equally extremely important. We're very conscious that the editorial board is very heavily older, male-dominated, which I'm obviously the prime example of. But I can say we are actively addressing that. Because we want, in fact, it was an interesting discussion I heard in relation to diversity in business. We're doing it because we want to, not necessarily because we're told to do it. And I think that's critically important.
Yeah. Mm-hmm. That's a good point.
I was going to move on, but before I move on, I think, get in touch with the ERC through your national council or directly through the website or the Young ERC if you're interested. Because we're always, because ultimately all these guideline organisations are volunteer bodies and everybody can volunteer. And if you're keen and willing, there's always a role for people. And so do get in touch. And I'm going to move the discussion on as we come into the sort of towards the last 10, 15 minutes of the discussion into, what's new out there. And I was going to get, Ben on, where's resuscitation going? What's the next big thing? Yeah. I was looking on the thing and some people were saying ALS is a waste of, it's all about the BLS, and things like that, and making things simpler, easier, human factors. And that's where we should be putting our money, So all that money you've got, where are you going to put it? What's the next big thing?
Right. These are important questions. I think one overarching concept that I would encourage all of us to look towards what's next, that applies to both BLS and ALS, is tailoring care or personalizing care. And I'll explain what I mean by that. And I'll start with ALS or post-arrest care. I think a really important paper to come out this last year that hints at a future for post-arrest care, and in particular TTM with tailoring of care, is from Cliff Calloway and colleagues who in JAMA Open and just within the last 12 months had a paper where they looked at how some patients in their large experience in their hospital system did better at 33. Some patients did better at 36 based on injury severity. So patients who had much longer downtimes, more organ injury, did better when they were cooled to 33 as opposed to 36. Patients who had shorter downtime, less organ injury, actually fared better at 36 and 33. Now, it's a retrospective paper. Why do I bring it up? I think it's a clue. It's a hint that, much of our obsession over the last few years in post-arrest care has been, 33 or 36, what's the right dose? And I think the answer is both. It's more about the patients. And so I think this concept in resuscitation has been for quite some time, one dose of this, one kind of CPR, one kind of, and I get it from a simplicity standpoint, that makes great sense. But at the hospital level, where we have all the tools and expertise available to us, I think we can do better. And I think looking at patient factors and physiologic response to treatment is going to be a big next wave. So, and that may be the ultimate unification of this debate of 33 versus 36. The answer is, well, for some patients it's one, for some patients the other. Now, this overarching concept could easily be thought of in terms of BLS as well. When we say CPR should be done for this long, in this fashion, for all patients, it avoids a huge thing in the room, which is, well, how's the patient responding to CPR given a certain way? There some time ago, I'm old enough to remember when we thought end-tidal CO2 would be the answer, where we could measure patient physiology during CPR. And I think largely those data are mixed and not quite as satisfying as we'd hope. But I think that the concept that we should be looking to patients' physiology and how they respond to treatment, this is deeply embedded in critical care and is no surprise to those who have been working in ICUs for years. But in resuscitation, I think we need to be going in that direction. I think we're seeing glimmers of that with this some thinking about TTM, but this could apply to both BLS and to ALS. And by the way, it could also apply to some of the very simple ideas of dispatch CPR or CPR training. Maybe there should be individualization of how we think about that as well, to optimize it in different environments and different situations.
Thank you. Jerry or Kuhn or Hildegard, any comments on that?
I mean, I agree. I think the concept of individualized care makes a lot of sense. I mean, one would like to see a lot more tailoring of CPR to individual patients. I'm still, well, perhaps we've been slightly disappointed by some of the end-tidal CO2 stuff. I think there's still more to come from that, actually. Certainly my personal experience is that it is actually pretty valuable. And maybe we just haven't got the science to back that up yet. So I think we will be seeing more of that. I think in hospital CPR, we're seeing a lot more, especially, I mean, in the States, you know, the vast majority of your in-hospital arrests, I know, are in an ICU setting, or at least a monitored environment. So maybe the use of intra-arterial and invasive pressure, for example, during CPR is actually potentially very valuable. So I think there's a lot more that can be done, certainly in the in-hospital setting at least, and maybe out of hospital as well, especially in those systems that have got physician-based systems or highly skilled paramedic-based systems, may be able to do much more of that even pre-hospital.
Okay.
Yeah, I agree. I also want to echo you, Ben, about tailoring training, because there is a session tomorrow, or even more than one, about education, and training is not just instructor-led, but it can be, you know, low fidelity, high fidelity, depending on the circumstances, can be on a mobile phone, can be on a virtual learning environment, and it's probably a mix of all these, depending on the person who needs training, on the environment, on the role. So again, this concept of tailoring and individualizing is very much applicable to training as well in education. So thank you for raising that issue.
Yeah. Hildegard, anything that?
No, nothing special for me. I think they have answered that, or given
I was going to pick Ben back up again. So clearly, it's an unfair question, but do you think we should be putting more effort at the front end rather than at the back end? You know, so early call for help, early defibrillation, early, you know, CPR because unfortunately, when most people have a cardiac arrest, they don't get Ben or Bella to turn up. They get someone who's never done it before, never seen it before, don't really know what's happening. Yeah. And that's the reality of it. Yeah. It's not Ben or Bella sitting on the ICU or in the ED doing some scratching his head and thinking, oh, what tailored approach am I going to take care?
Yeah, I agree. Not that I'm so good at the whole thing, so you're perhaps too kind, but no, I think that's right. I think that we do, of course, need to emphasize these things. You know, I think the simplest answer is we need to do all of it. But yeah, I mean, I think that certainly I would agree with the statement that you probably get more bang for the dollar, the euro, on the front end, with more CPR training and so forth. I brought up on this call was the notion of video support for maybe dispatch CPR. I think just-in-time training has been proven time and time again to be a very efficient way of helping people in need for these uncommon events, especially for bystanders who may have never done this before. And whether through telephone dispatch of CPR or newer modalities using video, I think it's going to be a very important approach and something that deserves a lot of attention. I know of many systems in the US that have really recognized now that not all dispatch CPR is created equal, that just checking the box and saying, you know, we have dispatch assisted CPR is not sufficient, that it really needs to be emphasized with more training, with more focused understanding of how it works and how to do it well. There's certainly doing it well and less well. And these are very important. And of course, without that, a lot of the post-arrest care modalities and emphasis may be less important. But I also want to say that the front end is getting more complicated. It's not just about dispatch CPR and CPR maybe anymore. There's growing interest, of course, in eCPR and the implementation of better technology on the front end with ECMO in the field. And there's been some very exciting reports. For those who haven't followed the story, I recommend it. For example, Dimitris Yiannopoulos and others just came out in the Lancet with the ARREST trial, which was actually stopped early because eCPR was so effective at saving lives from cardiac arrest that they felt it was unethical to randomize people to not getting eCPR in their environment, in their community. So the front end, while primarily I think about bystander CPR, recognition, dispatch CPR, it's becoming more equipped with advanced approaches even early on in the home setting.
Thanks, Ben. Anna or Jess, any questions or comments or from the feed, or any questions you'd like to ask?
So I think maybe just one for everybody. There's been a few people asking about why we don't have, why do the AHA and ERC have separate guidelines? Why don't we have one global set of guidelines that we all run together?
Jerry, then Kuhn.
One of my favourite questions, and I guess because I've been involved with it quite a long time now, probably should address that first. I think in many respects, in the ideal world, of course, we would have totally uniform guidelines. I think on a positive note, we are getting closer and closer together. So if you go back sort of 20 plus years, they were very, very different. What we're seeing now is with ILCOR, is really a review of the science behind cardiopulmonary resuscitation, and where there is consensus backed up by reasonably high certainty science, then we've got standardized treatment recommendations. And what we have agreed, AHA, the ERC, and all the regions of the world, is that the guidelines that we produce will at least be completely consistent with ILCOR treatment recommendations. So that, and in that sense, we have standardized. Where there are discrepancies and differences is in the subtleties of things like the algorithms, for example, that go down into the sort of detail of delivery of CPR, for which we really don't have high certainty evidence, in some cases no evidence at all. And it's there where there's differences in culture, there's difference in style in the way algorithms are done, there's differences in pre-hospital systems, for example. And I think it would be extremely difficult to end up with identical guidance and algorithms across the whole world, because it just would, there'd be so many differences in the systems. And in the past, we did try and do that at ILCOR, and it just led to an awful lot of fighting, basically, and got nowhere. So we agreed to go down to a level that we all agreed with, and then make fine tuning from there, which are the regional guidelines. So that's the honest answer to why it is what it is. I'm not saying that's right, but that's how we've ended up that way.
Kuhn, anything to add?
We'll see what the future will bring. Maybe with new people, more diverse people on both sides of the ocean. You never know. But as Jerry says, it takes a lot of effort to take the extra mile and sort out differences in cultures. And it's not just the American Heart and the ERC. It's also, there's Africa, there's South America, there's Asia. But there is a growing trend towards more global collaborations and approaches, but it will take many more years, and then we'll see where we end up. But it is certainly going in that direction.
Yeah, and I was going to flag up that it's very hard to write a single set of guidelines that covers all resource settings. And no matter how you think about it, the US has a much better or funded healthcare system than many countries in Europe. And they're willing to throw more money on bits of kit and stuff. So the threshold for doing things may be different, and for reasons, and the availability of drugs and different things is different around different parts of the world. So it's not actually that straightforward. And if you change the guidelines, so one thing that's come up quite a lot is, why don't the ERC recommend lidocaine? And because we already recommend amiodarone, and if you're already using amiodarone, is the switch worthwhile? Do you get more bangs for your buck for an equivalent? So we've never changed the guidelines unless there's a good reason to change them, because they have huge implementation issues. So a lot of the guidelines have been unchanged until we've reached a threshold of evidence to change them on a number of issues, and we haven't. I was going to say, We're coming up to the last 7 minutes. Anna, Koen's got a comment, and then we'll just do some final closing comments. Koen?
Yeah, thanks. Yeah, a quick comment about diversity and inclusiveness of low-resource countries, because what you just said, Jess, is Europe is mainly rich. America is mainly rich, but a lot of the people in the world who suffer cardiac arrest are not rich. Yeah. And also the caregivers are not rich. So we are making guidelines for, from our perspective, which is a rich perspective. So it's not just enough for the American Heart and ERC coming together and making, guidelines for the world. That's not the whole world. It's far from the whole world. So that's something else to consider. And we have been challenged for not being inclusive enough. So that's another challenge for the future. Taking into account areas in the world where there is not such a wealth as in many of the areas we know, that is something we really need to consider in the future.
Great. Last 5 minutes. So Anna, any burning questions for the panel?
What I found really interesting is that someone opened up the discussion for using ultrasound during cardiac arrest. And I'm sure that's something which has been established in multiple services. And there's many not very expensive little devices which have been established also in the aircrafts or on the HAMS cars. I would like to open a panel discussion on this topic. Thank you.
Okay, you've got 10 seconds or 20. Ben, you've written papers on this.
Hard to answer quickly. Yeah, I mean, I think it's something that is certainly being actively explored. We're interested in it. I think there's potential. In a way, it does speak to the issue of sort of the environment you practice in, and differences and capabilities of different places. So what I can do at Penn might be very different than at other places. I'm curious here. That's my 10 seconds. It's very dependent on where you are. Others should chime in as well.
It's in the guidelines. That's great. It's in the guidelines. Consider ultrasound. Jess, any final questions for the panel before final?
No, I think we've covered a lot this evening, which was good. I just say that you should all come to the Young ERC session tomorrow if you want to hear some more slightly wacky ideas of what the future of resuscitation looks like from the younger generation.
Great. Yeah, I was going to say, Hilda Gunnar, any final words or comments for the audience before it's getting late in Central Europe?
Yeah, that's right. It's getting late as well. But just remember, diversity is colorful, and what else than colors make us happy? So I think that's something that we should think about. Great.
Jerry, any final comments?
I think, Jazz, I'd probably just sum it up, and I think we all respect the fact that the earlier links in the chain of survival probably have a greater impact on overall outcome. We've all said that in various presentations, but I think it's really important that we should still strive to improve the quality of what we deliver in all links of the chain of survival. So whilst the ALS and post-resuscitation care may have relatively smaller effects, we should still be aiming to achieve the best we can for the patients. So therefore, improvements and highest quality across the entire chain.
So, and I wanted to get a Ben and Jerry joke in tonight, and I've not managed it, so I've just said it. Yeah. So we've managed to get Ben and Jerry on, which is great. So Ben, thank you for joining. I feel like a talk show host having a Hollywood star on. So any final comments before we let you go?
Well, my biggest final comment is I really look forward to the day when we can all work together on this. One of my favorite things about my career in resuscitation science has been the wonderful people. The resuscitation community is just full of kind, thoughtful, collaborative souls. And it's much better over a glass of wine and lunch and dinner as opposed to Zoom calls. So I look forward to the day when we can all return in fellowship to be in the same room.
Right. I completely agree. Koen, as the chair, final words for the session?
I couldn't agree more. Thanks.
So thank you to Anna and Jess and all our panelists, Hilda Gunnar, Koen, Jerry and Ben. Thank you to the audience for listening. The day starts early tomorrow with a World Restarter Heart session, and we've got speakers from all over the world talking about Restarter Heart initiatives. It's at the crack of dawn. Look on the programme, and thank you all for listening. Good night.
Thanks. Good night, everybody.
Thank you.
Bye.
Good night.
Good night.
Jazz, and thank you also. Bye. Take care.